Okay. Good morning to Dr. Saneej, who will join us from Australia shortly. It's 5 a.m. there. Good afternoon, good evening, everyone. Thank you so much for joining us. This is a very humble effort on part of our 2B candidates from overseas, from a wide array of time zones, to start practicing the 2B vivas in the 2B format. As we all know, the applications will open in February for us, and we have no idea who will get in. But still, whoever is lucky would have almost 2 months to prepare. So why not start now? There are various points which I have already shared with you guys. This is our first session. There can be a lot of hiccups. We are not perfect, but we are trying to practice. So let's start. I'll go first. And Iman from Egypt will be taking my viva, inshallah.
My pleasure.
Okay, so no clinical presentation. Okay. These are spot images from the intravenous spyelogram. The one which I have first is a 10-minute film, and the other one is a coned down view. In this 10-minute eye view film, I can see the contrast excretion from bilateral pelvic little system with outlining of the ureter and opacification of the urinary bladder. The left kidney demonstrates normal morphology of the pelvic little system. However, the right kidney seems to show the opacification of the lower pole moiety only, and the upper pole moiety is non-functioning. The reason I'm saying it, because this is causing a drooping lily sign on an IVU, which is one of the signs of a duplicated collecting system with hydronephrotic upper pole. I can have a delayed film for this film to outline it more. Usually in the duplex collecting system, there is a rule of Weigert-Meyer rule, where the upper pole moiety has a uretrocele and has obstructive uropathy, which leads to the hydronephrotic kidney, and it is ectopic in location, while the lower pole moiety has no orthotopic insertion usually, but it is prone to reflux and hence scarring. This patient would be referred to urology for further management.
Perfect. So just show the findings. Right side of the duplicated collecting system, the upper moiety is obstructed and inferiorly mimicking the appearance of drooping lily sign.
I hope candidate 5 has the timer on.
Yes, it is.
Okay, thank you. Okay, next case, diabetic patient presents off legs, dehydrated, fever, abdominal pain, infection in a 75-year-old male. Okay, so this is a supine frontal abdominal radiograph, which demonstrates a well-defined lucency in outlining the area of the urinary bladder. I'm trying to look for any abnormal air locules in either kidney, or whether it's outlining either ureter, which is a negative. I cannot. There is incidental finding of left-sided hip screw fixation. In this case, as the patient is diabetic and there is a linear lucency outlining the urinary bladder, emphysematous cystitis is the prime diagnosis. This patient needs to have a urine culture and refer to urology for management via antibiotics.
Do you want to do any further management?
A CT urography, a CT KUB will also help.
Great. So here is your CT.
Okay, so this is axial images CT scan, contrast enhanced in the portovenous phase. What I can see is airlock cues in the region of the urinary bladder. In fact, I think it is also going into the soft tissues. So this again reaffirms the diagnosis of emphysematous cystitis, but seems to be complicated with transection in the extravesical areas as well. This is going to go urgently to urology for the management.
Okay.
Okay, so this is an adult with sudden spontaneous onset of left-sided flank and abdominal pain. Okay, so this is a spot image, axial CT abdomen, contrast enhanced, portovenous phase. What I can see is there is fat density attenuation lesion in the region in the left kidney, exophytic. I can also see some heterogeneity within it, and there is a thick rim of soft tissue hemorrhagic density surrounding this left kidney. The visualized portion of the right kidney does not demonstrate any lesion. Considering a fat density lesion in the left kidney, along with high density fluid surrounding it, is highly suggestive of an angiomyolipoma, which has ruptured and is causing retroperitoneal hemorrhage. And this is, I think we call this as Wunderlich syndrome. And this patient needs urgent referral to the urology and also the involvement of interventional radiologist for coil embolization of the lesion.
Perfect, perfect. Thank you. Shall I skip to the?
Sorry, as you wish, Iman, as you wish. It's your call.
Okay. So, do you have any differentials?
Sorry, I missed you.
Do you have any differentials to give me?
Yes, in the differential, if I see such a fat density lesion in the retroperitoneal area, a retroperitoneal sarcoma is another possibility, but in that case, it wouldn't be have relation with the kidney. Secondly, there are times when there are fat containing renal cell carcinoma, which should also be kept in mind and can be one of the differentials.
Perfect.
Okay, 60-year-old male, a right flank pain, a right retroperitoneal mass lesion was noted on sonography for assessment. Okay, so this is a non-contrast CT where I can see a heterogeneous density in the region of right kidney. It does have fat tissue component, but it is very heterogeneous and not very clear, and seems to be very close.
Let me show you the corona.
Okay, you are a kind examiner.
So you can clearly see the kidney now.
Okay, so I take back the statement I gave before. This seems to be an extrarenal lesion in the region of right adrenal. It has a fat density component, and it is a sizable density. In my normal practice, I usually take an HU to determine and confirm the fat density and consider it as a sizable adrenal adenoma. However, a CT adrenal protocol or an MRI with an in and out phase would further help in the confirmatory diagnosis in this patient.
Good, here is your MRI. What sequence do you want me to start with?
A T2, a T1, anyone would be fine.
Okay, so I'll give you T1 with contrast
Okay.
and fat saturation.
Okay, this is a T1 fat sat. As I do not have an axial T1 fat sat without contrast, I cannot say for sure, but I think there is no significant enhancement on post-contrast images. And the fat sat means that there is also suppression of the fatty component, but still I have to see the in phase and the out phase for confirmation.
Okay. There is the in phase. We have the in phase here.
Okay, the in phase shows the lesion to have high fat component. Can I see the out phase? Yes, so this seems to be suppressed on the out of phase. Can I see the contrast images again? Okay, I was just trying to determine if there are components here which are not suppressed on fat and are enhancing. It is a bit of heterogeneous, but with the main component being suppressed on out of phase images, I'll keep my prime differential as adrenal adenoma.
Great. So can you give me any differentials?
Yes, again, a malignant tumor of the adrenal gland with a fatty component. Pheochromocytoma is not, I'm not putting it in the differential because it should be avidly enhancing and does not have fatty component. Yeah.
Please.
Sorry, I lost you in between. Sorry.
We'll just jump to the next case.
Okay. Okay, so this is a 40-year-old female patient treating urinary infection for 3 days, presenting with high fever and positive Giordano sign bilaterally, costovertebral angle tenderness.
This is the non-contrast.
Yeah.
Well, I want you to see the contrast enhanced.
Okay, so axial images, CT abdomen, contrast enhanced in portovenous phase. So this patient has presented with bilateral costovertebral angle tenderness. I think there is streaky heterogeneous enhancement actually of bilateral kidneys. I'm trying to look at the renal vein as well as to see if it's well opacified. And yes, it seems to be, yeah, can you please? The right, it looks fine, and the left, I'm assuming the left is also okay. Yeah, the left is also okay. So this seems to produce a sort of heterogeneous enhancement pattern, or a sort of, which gives me the suspicion that this could be a pyelonephritis. The renal veins are fine, so I'm excluding the renal vein thrombosis. The arterial emboli would not give to such symmetrical hypodense areas in both kidneys. So I'll go with the differential of pyelonephritis and refer to urology with the urine test and the culture for further management.
So this is a companion case.
Sure. So this is a 70-year-old female, underwent a contrast enhanced CT followed by CT 3 days before, CT angiography to rule out pulmonary embolism, and the creatinine values increased. Okay.
Just to put them after each other.
Okay.
With a very similar.
Okay, so this is a non-contrast, unenhanced CT, coronal images. It is showing actually hyperdensities in both kidneys in the pyramid fashion in the medullary region, which gives the finding of medullary nephrocalcinosis. This patient had CT pulmonary angio a few days before. I will also like to see contrast enhanced if possible. Or there is
this
none.
patient is having a raising creatinine, serum creatinine,
right?
And there's no calcification when we have the Hounsfield units of this. This is not calcification. So, can you put any other differentiator other than calcification to have the same density that you are seeing?
Then are these hemorrhagic foci in both the kidneys, or these are areas of renal papillary necrosis, which has calcified or which has become hyperdense, or I'm sorry, I'm making many R's. Again, I cannot call it a striated nephrogram, but a sort of streaky pattern.
It is.
Okay, on a non-contrast. Okay.
Yes, it is non-contrast, but it has retention of the contrast that is taken in the coronary angiogram she had a few days before.
Okay.
So
it's 15 minutes, sorry.
Okay, perfect. So we have 5 minutes as feedback. So persistent bilateral kidney enhancement containing multiple areas of high density striations of the renal parenchyma. Notice the lack of contrast in the vascular space. Minimal delayed excretion is seen as evidence of decreased renal function. So I haven't shown you the excretory phase. The delay, no excretion actually. None of them have an excretory opacified collecting system. So after the acute tubular necrosis, and this is exactly what you have said, striated nephrogram.
Right.
So this is the first neuron, as we always have been told, that trust your first neuron.
Yes, exactly.
Yes. So I'll just have a comment on the adrenal.
Yes, please. Dr. Iman, we can't hear you.
Now
yeah,
you can hear
you're
me?
fine. Yes,
Okay.
we can.
So this is a gross fat. One of the differentials of the gross fat in adrenal is
We lost you again.
I'm always mixed up.
Yes.
Myelolipoma.
Oh, okay, yes.
It's a rare benign lesion, but it has gross fat content with macroscopic fat content. Here it is. And this is one of the differentials which I mix up with angiomyolipoma and myelolipoma in the adrenal, angiomyolipoma in the renal, in the kidney itself. And adrenal, it doesn't have angiomyolipoma, which is very, very, very extremely rare. The one which is more common is the with these two things.
Right.
The emphysematous cystitis, well, you mentioned that it is complicated by rupture. Yes, exactly. It's one of the complications, but here was not a free gas. So I'm trying to get it back. these are contained too. It has a wall. So these are intestinal gas. There's no rupture here.
Okay.
Okay. So it's it's a complication, but now it's not an urgency. Not ruptured. Is catheterization and then antibiotics. If
Right.
there is rupture, there would be an urgency or an emergency. Other than that, you were more than perfect.
You were a very kind examiner, actually.
Thank you.
Thank
I'll
you.
just mute myself now.
And you'll have to stop sharing the screen. Yeah, thank you. Iman, it's better to keep yourself, okay, just keep the tab on the 15 minutes. Let me find Dr. Sanij. Can you unmute yourself?
Yeah, I'm here.
Thank you so much, Dr. Sanij. You are joining us at 5 a.m. from at a very early time, and really appreciate it. Thank you so much.
No worries. Thank you very much.
Can you see my screen, Dr. Sanij?
Yes.
So as we decided, now I'll take your Viva, and then you'll take the next 2 Vivas. Is that okay with you?
Okay. Yeah, okay. Fine.
Okay, go ahead.
Yeah, it's a 20-year-old male with a history of falling from height. So I have been given a frontal radiograph of pelvis. Since it is a falling from height, I'm looking for any fractures. I'm looking at the superior and inferior pubic rami, but I can see a subtle cortical defect at the superior and inferior pubic rami on the left side. So in this case, we have to think the possibility of any urethral or bladder injury, and I'll check the history of the patient, and we'll coordinate the next investigation accordingly.
Okay, so what will you like to do next? What should I give you?
Yeah, if there is any blood in the urethral meatus or any hematuria,
yeah.
So we have to do either a retrograde ureterogram if you are suspecting any urethral injury, or if you are suspecting any bladder injury, we have to do any CT cystogram or a CT abdomen with a delayed excretory phase.
Okay, strangely, this patient was then seen by orthopedics, and they asked for a CT pelvis. I'll show you the soft tissue windows first, and then I'll go to the bone windows. Okay. So
yeah, these are the plain axial non-contrast images of abdomen coming from below. I'm taking a moment to review the images. There is an interlink catheter in situ. The bladder is not well distended. I cannot see any free fluid in the pelvis, but in my normal practice, I will see in lung window and bone window also to see whether there is any free air and any to confirm the fractures that I have seen.
Yes. Okay. Good. Fair enough. Let me show you the bone windows.
So here I can see a displaced fracture, a minimally displaced fracture at the left sacral ala, and there is also a fracture at the ilium posteriorly on the left side. So I'm also looking at the acetabular. I can confirm a fracture of the superior inferior pubic ramus on the left side.
Yes. Okay.
And
can you see something else?
Yeah, there is some air within the urinary, but that can be due to interlink catheter. But I can also see some free,
yes,
free intraperitoneal air in
yes.
the pelvis. Yeah. So I'm thinking the possibility of any visceral hollow viscous perforation is a possibility. An injury to the bowel is a possibility.
Yes, this is anterior to the urinary bladder, right? As you see, this is the air within the bladder, and this is anterior to the urinary bladder. And yes, it's difficult to see here, but some free fluid as well. Excellent.
Yeah. Actually, the air within the urinary bladder can be due to this related to the trauma, and there is a catheter also. It can be related to the iatrogenic catheter insertion also.
Yes.
So this patient needs further evaluation with either CT cystogram or a multiphase CT with delayed cystogram phases.
Excellent. Okay, let me give you the portovenous phase.
Yeah, this is a portal venous phase contrast images. I'm seeing the images from below at the level of the bladder. I can see the bladder wall enhancement. The bladder is, I can still see the air within the urinary bladder, and I'm suspecting some a defect at the anterior part of the urinary bladder, which I'm not sure. I'll confirm it with a CT cystogram.
Yes. Okay.
And I see the rest of the series, and I'll also see the rest of the series in the upper abdomen to look for the other, if there's any other findings.
Okay, to confirm about these, to know the nature of these air locules and the free fluid, as you said, you can do either the delayed or the CT cystogram. Is there anything which you want to make sure? You mentioned it, but just for a repetition, before proceeding to CT cystogram, would you like to make sure of something first?
Yeah, I'll see the entire series first, like from upper abdomen to lower abdomen. I'll see the kidneys, everything. So here in the CT cystogram, I can see contrast extravasation outside the bladder, and there is extravasation of contrast extraperitoneally, which within the muscular and soft tissue planes of the pelvis. So I'm not seeing any contrast extravasation within the peritoneum intraperitoneally. So this is a extraperitoneal rupture of bladder. So I'll inform this to the referring clinician, and this patient needs to be referred to the urology consultants for further management. Okay. And I'll complete the study by seeing other sequences. Sorry, other sections.
Yeah, excellent. Okay, let's go to the next phase. Yes.
So it's age is unknown. It's a male. So patient is a victim of high-speed motor vehicle accident, brought to the hospital by a rescue team. He's hemodynamically stable, presenting with signs of peritonitis.
Yes.
So this is a contrast enhanced CT in the portal venous phase. I'm seeing the images from below upwards, taking a moment to review the images.
Sure.
So I can see the rectum, I can see the inguinal regions, the prostate. I'm looking for any specific findings here. I'm looking for any, there is some free fluid in the pelvis.
Excellent.
Surrounding the bowel. I'm looking for the bowel enhancement there. And also I'm looking for appendix and any signs of free air within the intraperitoneum.
Excellent, yes.
Okay, so...
What will you want to do next? This is portovenous phase.
Yeah, so if there are, I'm seeing the bladder wall that is, it's thickened.
Yes.
And there is some enhancement also. I'll see the delayed phases if there is, and also look at the lung window images if for any free air.
Okay, let me go first.
So this is a delayed images where I can see the vesicoureteric junction joining. It's normal, and I'm looking at the bladder wall carefully for any dehiscences or any ruptures. Yeah, I can see a bladder wall dehiscence anteriorly near the dome with a contrast extravasation. So it is an intraperitoneal rupture of bladder. I'll inform this to the referring clinician, and this patient needs to be referred urgently to the urologist for surgical management, as the management of intraperitoneal rupture is surgical suturing of the dehiscence.
Very nice.
Yeah.
Dr. Sanij, the best thing I like about you right now that we know that this is GU, but you are taking it as a de novo. Like you mentioned the appendix, you mentioned the small bowel, and that's how it should be in the real exam. You are not concentrating on the bladder. You are seeing the appendix and every cause which can be there in the pelvis. That's just amazing. Okay. Can you tell me the types of bladder injury?
The bladder injury can be different types. It can be intramural hematoma of the bladder, or it can be some shear injury of the bladder, or it can be extraperitoneal bladder rupture, as we have seen in the previous case. Yes. And it can be intraperitoneal bladder rupture. So usually it happens when the bladder is full and something kicking or any trauma to the full bladder. We see a tear of the dome of the urinary bladder, where we see the intraperitoneal rupture. And extraperitoneal rupture, usually it happens with pelvic fractures, as we have seen earlier. There will be contrast extravasation, extraperitoneal space. So usually the management will be putting of in indwelling catheter for the extra peritoneal rupture. But intraperitoneal rupture needs urgent management with the suturing of the dehiscence.
Very nice. Very nice. Okay. Thank you. Okay. Okay. These are no history. Okay. I'll just go through all the images.
So these are the static images of ultrasound of scrotum. The first image, the first image I can see both the testes, but the left testis is relatively hypoechoic than the right testis, and in the color Doppler also, that testis is showing any vascularity. I think that there is some enlargement of that left testis also. In my usual practice, I'll see the volume of both testes and compare. And I'm looking at the epidermis, and I'll also see whether there is any fluid within the scrotal sac, but I'm not seeing it. But the epidermis, it's also enlarged, and it's not showing any vascularity in the color Doppler. So I'll look at the clinical history, whether this patient is presenting with acute pain of the scrotum. Yes. In that case, it is suggestive of an acute testicular torsion. I'll see whether there is any whirlpool sign is seen at the scrotal root. It's not typical, but I see that there is some crowding of the vessels there without any vascularity. So it's an emergency. I'll inform the referring clinician, and will urgently refer it to the surgical team for further management. Excellent.
What will the urology ask, and what will be your question as well regarding the management in this patient?
The time duration from onset of the pain is important, because if it is only within, I think it's 6 hours, so we can manage and salvage the testis. Otherwise, we have to do a orchidectomy.
Yes.
If it is within that golden period, then we can do a orchiopexy and a fixing of bilateral testis to prevent the torsion in the other testis also.
Excellent. Do you know what bell clapper testicle is? What is the bell clapper?
Yeah, in some patients, there will be the attachment of the epidermis to the testis will be such that it promotes torsion repeatedly. That is known as bell clapper deformity.
Yes. So basically, yes, you are right. You're right. Okay, let's go to the next case. We can have the discussion later. Yes, go ahead.
So it's a 35-year-old female coming with flank pain. Yeah, these are the ultrasound images, static ultrasound images of the right kidney and the left kidney. I can see there is hyper echoic medullary pyramids bilaterally with some shadowing seen. So these are suggestive of medullary sponge kidney or medullary nephrocalcinosis. So I'll compare with the previous images if available, and I'll also check for the clinical history, whether it's a known case. So if it is not a known case, then I'll confirm it with a CT scan or an X-ray to look for. So this is the X-ray of the KUB region where the findings in the ultrasound is confirmed, where I can see multiple radiodense shadows at the expected location of medullary pyramids bilaterally in bilateral kidneys. So it's a nephrocalcinosis. I'm not seeing any other findings in the bones or any or in the rest of the abdomen. So I'll refer this whether this patient is a known case of any disease. So here, this is a coronal section plane images where I can see the calcifications at the expected location of the medulla.
Exactly.
So this is a medullary nephrocalcinosis or medullary sponge kidney.
Give me 3 differentials of medullary nephrocalcinosis. One you said, medullary sponge kidney.
So it can be sometimes it can see with papillary necrosis also. Calcified.
Yes.
Otherwise, it can be due to some renal tubular necrosis also is a possibility.
Yes, the renal tubular acidosis and hyperparathyroidism. Excellent. Yeah. Okay, your next case.
So it's a 1-year-old male with impaired renal function with no relevant perinatal history. Renal biopsy was performed, complicated by hemoperitoneum, for which the pelvic drain was inserted. So these are the static ultrasound images of the kidneys, where the right kidney, I can see it is uniformly hyperechoic cortex. I can see free fluid within the Morrison's pouch here, and I'm looking at the adrenal gland, and I'm also looking at the kidney. So taking a moment to compare both kidneys. So it's a axial and longitudinal section of the same kidney. Is there any Doppler images? No.
Unfortunately, no.
No, actually, I can see a uniform hyperechogenicity of the cortex. So it can be renal cortical necrosis, a possibility. Maybe like if there is any hypotension, can happen.
Okay.
This patient, since the history is showing some hemoperitoneum, there is a possibility that there is some hypotension and patient having cortical necrosis.
Okay, I'll give you a CT. It is there. So just to make things a
yeah,
bit more
these are the axial non-contrast images where I can see the findings in the ultrasound is confirmed, where I can see the cortex is uniformly hyperdense. So it can be cortical laminar necrosis is a means renal cortical necrosis is a possibility.
Yeah.
So I'll see at the lung window to see whether there is any free air, because this patient has a biopsy done, and there is I can see some free air.
Yeah, a bit.
It's 15 minutes already.
Oh, okay, thank you. Just a quick, you gave cortical necrosis. Any other differential in your mind, Dr. Saneed? Causes of cortical necrosis, maybe?
Like shock.
Yes, excellent. Yeah. Yes, excellent. I loved the way, Dr. Saneed, you presented, and as I said, I loved the way you took it as a 2B Viva and not a GU module Viva. Just as a review of the things you might have said already, but just for a quick review regarding the bladder injury types. Type 1 is only partial tear. The imaging would be normal. 2, as you said, intraperitoneal. 3 is intramural, as you said. 4 is extraperitoneal, and 5 is combined. One of the few signs which buzzwords we use in the extraperitoneal can be flame-shaped contrast or a molar tooth appearance. So these are the few buzzwords which we use for the extraperitoneal. For intraperitoneal, we say the contrast is going into the paracolic gutters and, you know, the in between the bowel loops. Otherwise, everything was fine. One thing which I wanted, which you said in the beginning, that before doing the cystogram, you'll check if there is any urethral injury or not, because you do not want to inject the catheterize the patient without confirming that, because there is a pubic rami fracture. Just be sure that the urethra is okay, and at times you can call the urologist to do the catheterization to avoid any you know, issues in the end. The torsion was perfect. The medullary sponge kidney was, you also gave the diagnosis. As we said, the differential would be hyperpara, renal tubular, medullary sponge, and we would, the treatment would depend on what the causative agent is. So I think, yes, everything was perfect here.
You are a kind examiner also. Thank you.
Okay. So Dr. Saneed, are you ready to take the Viva?
Yeah.
Okay, I think if Iman, are you okay if the candidate 5 goes first?
Never mind, I'm fine.
Yeah. Okay, candidate 5, can you unmute yourself, please?
Yes.
Okay, Dr. Saneed, it's up to you, over to you.
Can you see my screen?
Yes, I can. So it's a painless lump in the right testis, 30-year-old male. Okay, so I'm presented with the right testicle single image ultrasound, in which I can see there is a well-defined rounded lesion with the onion skin appearance in the center of the testis. However, I can't see any other lesion. I want to see the contralateral testis as well.
The contralateral testis was normal.
Okay, fine. So I want to see any Doppler flow or the color flow in it. So there is no color flow, appreciable color flow I can see. So this, the constellation of my finding is that it is onion skin appearance, and this rounded, well defined, and hypoechoic in nature. So first differential is epidermoid, but it is specific for the epidermoid onion skin, the testicular epidermoid. So I will inform the referring physician, and plus we will do the follow-up scan for this imaging, for these findings, and the surgical referral if needed.
Okay.
No history available, 65-year male. So I'm provided with the abdominal X-ray of skeletal mature patient, in which I can see there is I can see the bones appear normal to me. There is some, however, I can see there is radiodense area in the pelvis, plus the gas shadow seen on the right side. Yeah, can we show me the? Okay, so that's the and that's the nephrogenic phase, in which I can appreciate there is a left-sided nephrogram is obvious. However, on the right side, I can't see any nephrogram. So I want to go for further phases of the IVU. Yes.
So there is a delayed nephrogram from the right side. Okay, thank you. Great.
Okay, fine. Yeah, I can appreciate there is a dilated pelvic system on the right side.
Okay,
However, yes, on the left side there is specification of the renal pelvis. However, there is cortical collecting ducts are narrowed, and however both ureters are pacified, and contrast can be seen in the bladder. So, yes. So this shows that the right-sided hydronephrosis with the left-sided, as the collecting ducts are narrowed, and this shows there is some papillary necrosis of the left side.
There is some clubbing of the calyces, but that is due to hydronephrosis. There is no papillary necrosis.
Okay. No, I'm talking about the left side.
Yeah, the calyces are normal.
Okay, the calyces are normal. So I want to, and they are medially deviated. The ureters are medially deviated. So I want to look for any cause for pelvic lipomatosis or hematoma. I will ask for the previous traumatic.
No trauma.
No trauma. So I will look for the CT evaluation to look for any pelvic lipomatosis or retroperitoneal fibrosis. Okay. Okay. So left flank pain stones, 40-year male. So I'm provided with a CT axial slices non-contrast image, in which I can see there is liver appears mildly enlarged to me. So I want to go for, yes, spleen is normal. So yeah, both kidneys, the adrenals look fine to me, and bilateral kidneys, yes, are in normal in contour, and I can't see any calcific density. However, there is the left renal pelvis is dilated with the dilated ureter. So I want to trace on the left side. Okay, so I can see there is the soft tissue density mass in the just behind the aorta. Yes, so it's a retroperitoneal soft tissue density mass due to with the calcific speck in it. So yes. Okay.
Okay,
Yes.
carry on.
So I want to look for any other view if there is any.
Which way you need, coronal or sagittal?
Sagittal, please. Okay. So this clearly shows that there is a retroperitoneal mass due to which is causing the which is causing the medial deviation of the ureters. I want to look for on the coronal images as well. Yes. So my findings are there is the retroperitoneal fibrosis, which is causing the medial deviation of the ureter and causing the hydronephrosis on the left side. So I will correlate with the previous history of any medication history, or so further I will go for the other investigation like IgA nephropathy, the thyroiditis, any PSC, and other IG4 abnormalities to confirm my diagnosis, and further referral is suggested.
Okay.
Recurrent urinary tract infection, 25-year-old female. Okay, again, I'm provided with the IVU images in which this is a plain film. On the plain film, I can't see any radiodense area in the line of the KUB. Yes, on the 5-minute film, I can see there is a pacification of the pelvic lethal system, and they appears dilated. And on the left side, there is the ureter appears increase in caliber as compared to the right side. On 15-minute film, yes, and on the full pre-void film, I can see the excretion of the contrast on the bladder. So that shows that is the left megaureter. Plus, I want to see any post-void film if there is any to look for. Okay, so there is a complete excretion of contrast after post-void. So this signifies that the left-sided megaureter. So on right side, the kidney appears normal and is normally excreting. Okay, so further, a urological referral is suggested.
For what?
What will
you tell to the urologist?
To look for any development of the what we say. No, I'm not sure. Sorry.
Okay.
Right side abdominal pain and urinary tract infection, 35 years female. Okay. That's the again I'm provided with there's a contrast image. That's the IVU image.
It's a plain X-ray.
Okay, that's the plain X-ray of the abdomen of skeletal mature patient, in which I can see there is calcified lesion involving the right renal area. However, I can't see any radiodense shadowing on the left side. Yes, so the calcified lesion is getting the position of all the pelvic system, and it's enlarged in size. So that shows there is some Staghorn calculi. I will correlate with the ultrasound to look for any hydronephrosis or obstructive uropathy. So, and then I will refer to the yes. So on ultrasound images, there is dilatation and hydronephrosis of the right kidney with the calcified foci causing the acoustic shadowing. So that shows there is a Staghorn calculus, which is causing the hydronephrosis and hydronephrosis. So I will refer this patient to the urology department for further management.
What's your diagnosis? What will you tell to the urology department?
So it's the Staghorn calculi which is causing the hydronephrosis.
Okay, so you're happy with your diagnosis, so you will send no further investigation is needed?
No, I will go for CT if CT is the main for to confirm my diagnosis. Okay. So okay, on CT, yes, that's the bone window, in which I can. Yeah, can you show me the contrast images? Yes. So on the exercises on the portovenous face, I can see there is again the large calcified lesion involving the renal pelvis as well as the pelvic system, and there is, along with the hydronephrosis, with cortical thinning and some of the perinephric stranding as well. However, contralateral kidney appears normal. So I want to look for the yes, and that confirms that it's the Staghorn calculus causing hydronephrosis and obstruction. So I will refer the urology team for any piece to remove the or intervention radiologist to get rid of the obstruction, and for any intervention like PCNL.
Okay.
Asymptomatic patient came for CT scan to investigate renal stones. The patient had surgery to remove calculi 7 months earlier. Okay, so that's the plain radiograph of the skeletal mature patient of abdomen and pelvis, in which I can see there is calcific density, radiodense areas involving the bilateral.
Sorry to interrupt. 15 minutes are up, just to let you know.
Okay. That was a very good presentation. Congrats. But let me see the images first. So this is a right side abdominal pain and urinary. So this patient has urinary tract infection. So that is important. The patient is not presenting with any acute flank pain or any obstructive symptoms. And you have found out this X-ray, but you are a bit confused whether it is an IVU. So that happens because it's a Staghorn calculus that is taking the shape of the pelvic alical system. So you finally told that it's a Staghorn calculus, and there is a another calculus here. There is a that was confirmed in ultrasound. But to say it is a hydronephrosis, it should be connected. Like the pelvis will be enlarged, and there will be connection of pelvic cell system. That's how we differentiate hydronephrosis. But it's actually, these are hypoechoic areas within the renal parenchyma, which is not showing any vascularity in color Doppler. So of course you can say it is hydronephrosis as a differential, but you have to raise the possibility that this can be hypoechoic areas within the renal pelvis. And use, but you did not say anything for further. But only with the ultrasound we will not manage anywhere the patient, and we will not send the patient to the urology team unless it is confirmed. So you have to suggest CT scan, but only after prompting you told you will suggest CT scan. And this is okay. There is a Staghorn calculus, but you have to use the buzzword like it's a typical beer paw appearance of xanthogranulomatous pyelonephritis. And these are not hydronephrosis, because the pelvis here, you can see the pelvis that is not that much enlarged. These are the hypodense areas within the kidney, which is not showing any enhancement, and that is hypodense. So this is a xanthogranulomatous pyelonephritis, and of course you have to refer this patient to the urology and do adequate management. And regarding the previous patient with recurrent urinary tract infections within 25 years, so you did it. Okay, so the plain scan, there is not much finding, but you found out that there is some enlargement of the left ureter, and the left distal ureter is obviously enlarged. And you can see there is a cobra head appearance. You have to use the buzzword like cobra head appearance, a very smooth halo around the left distal ureter. And you have to describe the halo as it's a very smooth, thin. There is no irregularity. No, I'm not seeing any calculus, and no, I'm not no obvious mass. Like there is no irregularity, but you can confirm it with CT, and you have to raise the possibility of ureterocele causing obstruction. And obviously you have to refer it to the urologist and confirm it with a CT scan to rule out any pseudo ureterocele. But for me, it's a true ureterocele with smooth halo, and you have to say the negative findings to rule out as pseudo ureterocele. And the pseudo ureterocele can be caused by a calculus or any mass like that. And this case, left flank pain, stones, 40-year-old female. In the CTKB, actually it was a companion case to the previous one. You found out the liver enlargement, but you have to say that its hypodense related to the spleen. You can see the there is a fatty infiltration of the liver. CT, and in my normal practice, I will compare the CT density of both the liver and the spleen to see whether there is a diffuse fatty infiltration. There will be more than 20 HU difference. And you found out the adrenals are normal, kidneys are normal, and there is a mass here. But it's a plain scan, so you have to definitely ask for a contrast scan. But there's a contrast scan available. Only if you ask, you will get the contrast scan. But you have to tell the DD also, because it can be due to lymphoma also. Like you have to see what is the status of the aorta, whether it is pushed, whether it is displaced, whether there are any other lymph nodes. So you have to ask for a contrast, but you didn't ask. You have to earn the image. Only if you ask, the contrast will be given. So in the contrast, you disregard this seroma. You can see the it's moderately enhancing, and the aorta is not that much lifted from the vertebra, and that is encasing. And you can see the as you correctly told, there is a hydronephrosis on the left side, and the ureter is going within the lesion. That is clearly seen with the medial deviation of the ureter is clearly seen here in the contrast. You can confirm it in the coronal scan. And then you can say the retroperitoneal fibrosis as a primary differential, primary diagnosis. But lymphoma is the differential, but I am not seeing any lymph node enlargement, and I am not seeing any other lesions in the abdomen. So how will you confirm? You can do a nuclear medicine FDG PET scan, where the lymphoma, it will show some uptake, but here there is no uptake. So that's retroperitoneal fibrosis.
Yes. Yes.
So these subsequent images, they will show only if you ask. In this case, 65-year-old male with no history available. So this is the same case. You found out there is delayed nephrogram from the right side, and there is hydronephrosis on the right side with compared to the left, and there is medial deviation, and you can tell that I am suspecting the possibility of pelvic lipomatosis. You told the history of trauma, hematoma, retroperitoneal fibrosis. That was excellent. And painless lump in the right testis. So this was the first case. You correctly used the buzzword onion skin appearance. Congrats. So you had to say it's a well-defined lesion, and you asked for a color Doppler. That's good. And you told that that is an avascular lesion. So you substantiated that it's a. You said that you look at the other testis, and I told that the other testis is normal. That's also very good. And considering a hypoechoic lesion without vascularity in a testis with onion skin appearance, you are considering the possibility of an epidermoid. That's also good, but you have to confirm it. Like whenever you see and you told that it's not, it can be non-specific also, but you have to consider the possibility of a malignant lesion anytime you see a mass lesion in an adult. So you will discuss it with the clinician, and you have to correlate with the serum markers. You didn't tell about serum markers. So if the serum marker is elevated, then you have to definitely look for other causes like seminoma or non-seminomatous germ cell tumor, and do a staging CT and all. Otherwise, as you told, you can do a follow-up scan later. So and you have to tell because the diagnosis of the epidermoid is good for the patient, because they can do a testis sparing surgery. So you have to show your knowledge to the examiner without asking. You have to tell everything. So it was a good session. Thank you.
Thank you so much. Thank you so much. It was brilliant.
Anything extra to add, Sahabat or Iman?
No, thank you, Dr. Saneej. That was excellent. The feedback was excellent. And thank you, Candidate 5. You were very nice. You were amazing. And it has helped everyone a lot. Dr. Saneej, you'll still continue with Dr. Iman. Is that okay with you?
Yeah, let me take the next
Sure.
film.
Sure.
Yeah,
Iman, can you unmute yourself?
I already did.
Okay. And thank you for all the participants who are joining us. Just to let you know, I have enabled the chat. So just don't discuss the diagnosis as of yet, but you can put down your suggestions and how to improve the sessions, anything you want. And Dr. Saneej is now going to continue with the Viva of Dr. Iman, which would be the last session, last hot seat session now.
So we'll start from the, can you see my screen? No?
Not yet.
1 second. Sorry, I can't see the share screen option here.
It should be the same way as at the bottom, or maybe the bar.
One second.
Sure.
Oh, okay. Can you see the screen now?
Yes.
Okay.
A presentation, symptomatic patient came for CT scan to investigate renal stone. The patient had surgery to remove calculi 7 months earlier. 70 years, female. This is a plain KUB radiograph showing bilateral high density involving both renal, occupying the renal area bilaterally, with the punk calcification, while assuming that there was a stone a procedure, extraction procedure 7 months earlier, so I think this is a residual. So I would like to confirm my my professional.
Can you keep your mic a bit closer?
Is this better?
Yeah, good.
So I would like to confirm my provisional diagnosis by CT without contrast first.
So I didn't hear you. What did you tell?
Well, I presume that this is residual of the stone, which was there 7 months earlier. So I would like to confirm it because it's in the confinement of the kidney, of the right kidney.
Okay. Okay. How did you confirm?
By CT without contrast first, please.
Okay. So these are only selected images. This is a, it's not a scrollable. I think it's scrollable. Yeah. Sorry.
Okay, great. So yes, exactly. There are multiple residual high densities involving both renal, pelvic, pelvises. They don't seem like stones. They are, yes, they can be fragmented stones, yes. These are fragmented stones, more prominent on the right side. So this is non-contrast CT again. I'm trying to track the ureters, but I lose the track. So can I say a coronal?
I have a bone window coronal only. Sorry.
So these are residual fragmented stones bilaterally, renal, in the renal pelvises, with the minimal back pressure. There is no obvious stones involving in the ureters. I think I saw one on the left ureter.
Yeah, there's one. Yeah.
Yes, at the level of L4, 5, I think.
Yeah, disregard that. No worries.
Yes, okay. So I would inform the referring physician and refer to the urologist for further consideration of urinary.
So what will you tell to the urology consultant, your professional diagnosis?
Residual fragmented stones, which needs to be repelled out.
Okay.
With ureteric catheters or whatever they use. Bilateral acute parotid swelling with fever presents with right side scrotal pain, ultrasound to rule out orchitis. These are selected ultrasound images of both testes. The right and the left testes shows punctate high foci of high echogenicity, scattered all over the testicular parenchyma. No obvious masses or hydrocele. There is a very minimal hydrocele on the left side, fluid rim. I would like to examine the vascularity of both testes.
The vascularity of both testes was normal in color Doppler.
Great. So parotitis and orchitis. Well, this is, I'm trying to remember the name. there's microcalcifications of testicles, which are, I think these are pre-malignant. So this patient should be observed and followed up each annually. So I would refer this patient for follow-up. Testicular pain, 22 years old. Okay, this is the right testicle ultrasound showing there is a well-defined in this selected image. There is a dilated epidermal. There is a cystic lesion at the epidermis, at the head of the epidermis. And in the first image, there was a focal area of hypoechoic lesion with high vascularity, showing high vascularity in the Doppler. This lesion is well defined yet irregular outline. He was 22 years old, male. So the rest of the testicle is having normal vascularity. I would like to review
so I'm showing you the right testis first. So you describe the epidermal cyst. So I'm showing you the right testis, the vascularity. Okay.
Okay.
Now I'm showing you the both testis, right and left.
Yes. Both testicles have homogeneous echogenicity. With I think the left one has microcalcifications as well.
Okay.
There are multiple hyperechoic foci.
So we are coming to the left testis. This is the left testis.
Yes, great. Showing microcalcifications as well with irregular hypodensity, and I'm suspecting a neoplastic process here, considering the microcalcifications and multiple hypoechoic areas or rules. And this one is irregular and the largest one. So I'm considering seminoma or teratoma, and this patient should be referred to the MDT, the urogenital MDT, for biopsying this testicle and I don't think we have to do MRI for this. So I think CT, chest, abdomen, pelvis should be considered for staging. Bilateral flank pain, 18 years, female. Plain KUB, end of injection. I cannot appreciate a significant abnormality, yet there is a soft tissue, ill-defined soft tissue shadow involving the pelvis.
Yeah, that was fibroid. Disregard that.
Okay, thank you. Both kidneys show outline, which is the outline of the kidneys are a little bit medially rotated, or I mean, they are so close to the midline with the horseshoe alignment, I think. So I'm suspecting a horseshoe kidney. So I would like to, yes, go for the post-contrast. The left ureter is opacified with medial, what do you call it? Medial movement or retraction, and both kidneys are approximated at their lower poles with mild hydronephrotic changes. The urinary bladder is opacified. The right kidney doesn't show an excreting ureter. It's not obviously seen in those shots. So I would like to ask for CT for further assessment of the right ureter.
Okay, so what's your primary diagnosis before going to the CT?
Horseshoe kidney with partially obstructed pelvic system bilaterally.
Okay.
Trauma with displaced pelvic fractures, 20 years, male. Okay, this is an ascending cystography, ureterography and cystography. The ascending, the urethra, the anterior and posterior urethra. The anterior urethra seems to be normally opacified. The posterior urethra shows irregular outline with extravasation of the contrast. Yet the contrast reaches the base of the urinary bladder. So I'm suspecting a posterior urethral rupture or injury, which is obvious in this. This is I would immediately inform the emergency doctors to avoid catheterization for this patient. And refer this patient for a urological consultation for
which part of the urethra is injured here?
I think this is the posterior, the membranous urethra, I think.
Okay.
As far as I can see. No clinical presentation supplied by author. Okay. This is post-contrast, post-oral contrast CT of the abdomen and pelvis. It's a bit slow at my end, so I'm trying to follow up. Opacification of intestinal loops. Okay, this is post-IV and oral contrast. It's a female, as I can see the uterus now. The right kidney appears now to be, okay. Both kidneys shows mottled contrast enhancement. The left kidney shows an exophytic, large, hypodense lesion with fat densities, which shows mottled contrast enhancement. This lesion is well defined with partial contrast enhancement. Yes, I cannot see the collecting system. Well, sorry, I can see fat stranding around this left lower pool lesion.
Just to let you know, 15 minutes are up.
Okay.
So my primary diagnosis would be angiomyolipoma.
Okay. But so you are correct. It's an angiomyolipoma. So here you have to say like the size of the lesion is more than, I think in your normal practice, you will measure the size of the lesion. And I think if it is more than 4 centimeter, it looks like more than 4 centimeter, then there is an increased chance of intraperitoneal hemorrhage. So I'll discuss with the clinician the possibility of an intraperitoneal hemorrhage. You can also inform the interventional radiologist for a preoperative embolization and further management. So you have to say that the borderline size will be 4 centimeter before any intervention. And it's a trauma with the pelvic fractures. You correctly told this. It's a retrograde urethrogram. And you have to say that the penile urethra is normal, the bulbar urethra is normal, and you told the anterior urethra is normal. That's fair enough. And the posterior urethra is abnormal. This is the membranous urethra. You told it correctly. And there were some in the history itself. They were telling like multiple fractures. You don't need to mention it. So this is a contrast from the previous CT. The ureter is not a reflux. But you have to tell that the contrast is going into the bladder, that you told correctly. So it's not a complete rupture or complete tear of the posterior urethra. It's an incomplete injury, and there is some contained leak that you told correctly, and you have to inform it to the clinician. And you told that you will ask them to avoid catheterization, and we'll refer to the urology consultant. That's good. This is a case with bilateral flank pain, 18-year-old female. So you told it correctly. There is some medialization of the lower pole of the kidneys, and you have to use the buzzwords like flower-wise arrangement of the calyces. And you told correctly that there is a bilateral hydronephrosis, and you look for the cause of the hydronephrosis by doing the CT. But here the finding of horseshoe kidney and using the buzzword flower-wise appearance of the calyceal system is enough. And you have to also tell that you are looking at the vertebrae for any vertebral anomalies. There are no vertebral anomalies here because rarely it can be associated with the vertebral anomalies in the vectoral.
Right.
Yeah. You have to just mention about the vertebra. And testicular pain with 22-year-old male. Yeah, you told it correctly. There is a actually there is a microlithiasis on the left side. You told it, and there is some minimal microlithiasis, 1, 2, or 3. I think more than 5 echoes on the right side also. And it's a very well-defined lesion, and you are suspecting the possibility of a seminoma. You told it's a very highly vascular. So you have to suggest a staging CT examination that you suggested, like staging CT of chest, abdomen, and pelvis, to look for the first it will metastasize to the paraiotic lymph nodes at the level of kidneys. Then it can go to liver, lungs. So you told it, and you have referred it to the urology MDT. And you have to correlate with the tumor markers also. And biopsy and all that will be decided in the MDT. So you just refer it to the MDT, and they will decide whether it is to be biopsied or not. So the history is a bit misleading. Bilateral acute parotid swelling with fever. It's an incident. So what they are trying to show it's an incidental finding. And you told there are microlithiasis, and you asked for the Doppler examination, and that's correct because we are suspecting any orchitis. So you have to look at the color Doppler examination, and you told us correctly, like it's a some are considering it as a pre-malignant lesion, and there is a difference of opinion, but you can tell what it is followed in your institution. Like you told that you will do an annual ultrasound, but you can substantiate like that. In my institution, it is followed like we will follow it with every year, but in some institution they will follow every 6 months. So there is no hard and fast rule how the follow-up should be, because there are some different opinions in different reports. So you can say what is followed in your institution, that you have clearly told. And asymptomatic patient came to CT scan to investigate renal stones. The patient had surgery to remove calculus 7 months. So it's an asymptomatic. So here, in addition to the calculi, you can see some air lucencies bilaterally. Here you can see the air lucencies admixed with the calculi that you have to tell and raise the possibility of any emphysematous cystitis or emphysematous pyelonephritis. But this is, you did not ask for the ultrasound, but you can very well go directly to the CT. But in this, you can see the air within the urinary bladder. And there is also air within the renal collecting system. There is no air in the renal parenchyma, only air within the renal collecting system with multiple calculi, as you told. And that is clearly seen here. Yeah, multiple emphysematous pyelitis. And you have to see lung window also, because there are free air within the intraperitoneum. Pneumoperitoneum was also seen. So it is a case of emphysematous you can see the pneumoperitoneum and emphysematous pyelitis with the pneumoperitoneum. So that is the first case, right?
Oh yes, yes. Can I say, can I mention that okay, it cannot be post-surgical because it was 7 months earlier. Okay,
you are telling like iatrogenic air, or it's very unlikely.
Very unlikely. Yes, I remember
7 months. Yeah.
7 months. Yes, it was 7 months earlier. Thank you very much, Dr. Saneej.
Okay.
Yes, Dr. Saneej, thank you so much. Thank you, everyone. And the comments and suggestions are welcome on how we should run the session and how we can improve. If anybody wants to make a comment or suggestion, you can raise your hands and I can unmute you. Dr. Saneej, a special thanks to you that you joined us all the way from Australia at 5 a.m. in the morning and woke up so early. Thank you, Iman. Thank you, Candidate 5. It would not have been possible without you. And I hope that, we'll get more and more volunteering. This is a very friendly environment. We just want to practice. You have seen how we all have made mistakes and we will learn from it. None of us are perfect. Dr. Saneej, Dr. Iman, if you want to add something?
Yeah, actually, everyone should come forward for the volunteering as examiner and candidate, because don't worry about what others think and don't worry about your mistakes, because we are not looking at the mistakes or we are not assessing the candidates. We are looking for only the how the presentation is done, and the mistakes are always welcome because we can learn from mistakes only. And we are expecting more volunteers in the next session.
Yes, Dr. Iman, do you want to add something?
It was very helpful to be an examiner for the first time and being examined by someone who is my colleague makes me more comfortable. And I missed a fatal case, but I think Dr. Saneej got me the information in a very easy and nice way. So I liked it so much.
Thank you. Missing a case here is not an issue, because you have to miss the case here so that you will not miss the case in the real exam. So now onwards, you will be very careful looking at the air in the renal pelvic ileal system in all your cases. So that is a learning point here. So missing a case is not an issue at all here. That's not